process. And the copious use of coupling agent is given so that you do not apply pressure on the globe when you are taking this. And the dosage of 20% sodium fluorescein is 0.04 ml per kg, or whatever works out to 8 milligram per kg can be given. And then you click picture in all the directions. Best is to get a video, and from video you extract the pictures. That works very well for these babies. You see the choroidal vasculature filling in, then the retinal vessels filling in, and you must focus at the junction of vascularized and avascular retina, and you would pick up a lot many things. And be careful that you have to be recording the temporal, nasal, and superior and inferior part of the field, and I do it under topical anesthesia, because general anesthesia, usually it's very difficult, and it works pretty well for these. Now, first you look at what you are going to see is you're going to see the choroidal vasculature also. You could pick up areas of hypofluorescence, which are surrounded by the area of hyperfluorescence. You could also pick up these watershed zones. We still have to see how they correlate with the final functional and morphological changes in the retina. But you do see lovely choroidal pattern, and then once you acquire the fluorescein angiography, you see the arteriovenous shunts can be seen, abnormal vascular branching can be seen, some hyperfluorescent leaking lesions can be seen. They have to be documented. Once it comes to explaining what a fluorescein angiography is, that would go as what zone you are seeing, the junction of vascular, avascular retina, and then what kind of leakage you are seeing. And it says that FFA increases the percentage of detection of treatable ROP, because it increases it to 40% from 22.2% of the cases which you diagnose clinically. There's significant variability in the diagnosis between the experts and non-experts. It has been seen that fluorescein angiography images, the expert interpretation matches the non-expert, and we have newer people joining ROP treatment. Whether to treat or not to treat, they have to decide. So FFA could be adding objectivity to that. Then with the newer classification, you have to identify the zone, which will tell you the notch also, which could change the zone. So FFA helps to identify the notch. If you look at this, the clinical picture lower down, in fact, you would call it as zone 2 ROP. But once you do fluorescein angiography, you realize that it's just approaching the fovea, the center of the fovea, because of the notch, and similar is the next picture on the right. In our study, we found out that whatever we had labeled as type 2 ROP clinically, around 1/3 of those were actually requiring treatment due to the intense leakage which we were seeing on fluorescein angiography. Therefore, FFA could help you to increase the sensitivity of diagnosis of treatable ROP. And it unveils a lot many things. You see focal dilatation of capillaries, you could see popcorns, arteriovenous shunt vessels. You could also pick up something like foveal hypoplasia in these babies, which could have impact on the final visual acuity of these babies. Now you could see something like this. There's neovascularization of disc, and macula is hardly formed. You do fluorescein angiographies, you see this 4-lobe pattern, and you see macula is not even perfused. So this could have helped you to prognosticate the baby. This is another similar kind of picture seen. And you tell us exactly like whether the fovea is perfused or not perfused. Looking at this tells you that you need to do FFA to prognosticate the baby, and tell the parents, well, the fovea has hardly got perfused, so whatever treatment we are going to do, we do not know about the vision, and the final, that saves you. I mean, medico-legally also it saves you. Then you could pick up certain non-perfusion areas which are there in the vascularized retina. This is another one, non-perfusion area, which is surrounded by arteriovenous shunt vessels. And these also need to be treated while you are doing laser, these capillary non-perfusion areas. Aggressive retinopathy of prematurity, yes, it helps you to pick up flat neovascularization in a better way. And if you say that type 2 ROP, we had done fluorescein angiography on all the babies with type 2 ROP, and then we could see that delayed arterial perfusion, and popcorn lesion were the prognosticators of the progression of retinopathy to type 1 ROP. If you score, Barilla et al. Study helps you to score fluorescein angiography on the basis of leakage, ischemic area, plus disease or vascular anomalies. And it has been seen that FFA score of 7 or more, 100% of these babies would require treatment in 2 to 17 days. And once you've already treated, you could pick up certain abnormalities on FFA. You could pick up microaneurysm, you could pick up skip areas, and foveal hypoplasia. This is just showing you that this is skip area which was left between the vascular-avascular area and the laser marks. You can go ahead and that helps in better treatment. The recurrence of ROP, the role of FFA is a lot because you need to pick up this peripheral avascular retina, which is 2-disc diameter of avascular retina seen in the periphery. And it has been seen that 100% of babies whom you give anti-VEGF at 4 years of age have this peripheral avascular retina. So I intend lasering all the peripheral avascular retina if it is present at around 65 weeks or so. And lower down again, it's showing the recurrence. The recurrence could be seen at the point where your vessels have progressed at that edge, or our initial ridge area could again get, could become leaky. So summarizing, FFA is a highly informative and safe modality that increases accuracy of diagnosing treatable ROP. FFA parameters can predict the course of the disease. FFA has a definitive role to follow up the babies, ROP babies who are treated with anti-VEGF therapy so that you could treat them whenever recurrence is there or treat the peripheral avascular retina. It unveils the unknown, which might help to prognosticate the final visual acuity in these babies. Thank you.
You see, FFA, it is not available in our center, in other centers also, but how beautifully she presented. So if you have any question, please ask her. And we have 2 presenters is not there, so probably we can ask few questions to her.
And how frequently do you do FFA? Like, do you
Look.
pick up all the babies or just selective babies?
Not all the babies. Initially, we started doing as a project on all the babies who get ROP.
Okay.
Okay, whosoever gets ROP, because we used to, we had to tell what babies, what are the predictors of development of type 1 ROP, because all the babies who get ROP don't land up in treatment.
Yes.
So that is the time we started doing it, but now we do it in select few.
Okay. Thank you.
And if I ask one question, Dr. Subina, that how much you inject the fluorescent dye for the babies?
20% we take, sir, 0.04 ml per kg, which is very little. Initially, when I was injecting 0.1 ml, I said, well, it will not come. But then it comes beautifully. The moment you do saline flush, it comes.
Okay. And that is the timing, that is, when do you do this? It is compulsory for every type 1 ROP patients or aggressive ROP patients? You
So
do this?
it is not compulsory for anything. We yet have to come out with that kind of data. What we did was anybody who develops ROP at the initial stage type 2, we start seeing the patient is not plus disease, we do not know patient will progress or will regress, we would do FFA. Then in the end we came out with the data that all the babies with delayed arterial perfusion and popcorn lesions are going to progress to type 1 ROP.
Madam, it's excellent presentation. We don't have
Thank
FFA at our center. I wish we did. Obviously, there's a lot of information to be extrapolated from that. But my queries were about the adverse effect. What are the adverse effects and side effects and unwanted effects that you have faced so far?
None. We've had no side effects, no adverse effects. Though literature calls it, like if you do it for small kids, less than 5 years, they've picked up 0.57% of bronchospasm. That's the largest study on small babies, which is 349 babies they've done. But in our setup, we've not had any complication.
So what are the precautions you take? Any extra precautions?
Half an hour before the procedure, we feed the baby, that's it.
What are the things we need to explain the parents before doing an angiography? Like, do we have like in adults we say that you might have some nausea, you might have some vomiting.
The baby would have, first thing is baby gets a renal function test before we take up the baby for the procedure. Then we tell them that the urine is going to be yellow, slight skin discoloration would be there. But then the parents understand, and they are very happy looking at it. They would see, okay, this much of vessels have developed. So they see a dynamic kind of thing. You show them the videos, they feel, okay, whatever you're doing. In fact, that has increased the compliance of the parents to get the baby.
So which machine you are using? That is it
Redcam.
Redcam only?
Redcam.
It is not available with Indian-made 3-netra?
No, it's available now, sir. They have come up, we've done a trial cases on that also. It works equally well.
Okay,
But all these images were Redcam images.
excellent.
So we'll go to our next